Hello everybody, welcome to the Mayo Clinic. I'm Christopher Camp, and I'm one of the orthopedic surgery and sports medicine physicians here at the Mayo Clinic. Today, we're going to be discussing some of the intricacies of the elbow exam. I know for a lot of people, the elbow is somewhat of a black box. It can be a little bit difficult to determine different pathologies, both clinically and on physical exam. So today, our goal is to sort of help you sort through that. I have Sarah here with me today, so she's going to help. She's going to serve as our model, and we're going to demonstrate a relatively complete and comprehensive general elbow examination. For me, anytime I'm approaching a patient who has an elbow-related issue, I try to keep things organized in my mind. There's really 5 different components to the exam. The first would be elbow range of motion. Next, we'll look at the elbow in 4 different anatomical sections. So first, we'll look at the anterior aspect of the elbow, then we'll move to the lateral side, then we'll do the posterior elbow, and finally, we'll finish up with the medial elbow. So I try to keep everything compartmentalized in my mind that way. That helps me when I'm taking the patient history and also when I'm organizing the exam in my mind. It's also how I sort through the imaging and ultimately come to the final diagnosis and treatment plan. So with that, we'll jump right into it. First thing I'm going to show you is elbow range of motion. Now this can be a little bit trickier for the elbow compared to other joints, and that's because the elbow flexes and extends, but also rotates, and the fact that it's attached to the shoulder, which is obviously a very freely mobile joint. So a few very minor, but I think important tips that I like to use. So first we're going to look at her right arm. I like to bring the humerus up so that it's parallel with the floor. Next, we want to supinate, which maximally externally rotates the shoulder. So that way the anterior surface of the humerus and the forearm are both facing the ceiling. It's helpful for me to have the humerus parallel to the floor because then that gives me a good frame of reference for the range of motion. And that way I know that any motion that I see is actually coming from flexion extension rather than rotation. So for full extension, I'm going to support the arm, maximally extend to their level of comfort. Obviously here, a straight line is 0. And then we'll come up for maximal flexion. I kind of think of the coordinate system in my mind. So I know if I'm up here, that's a right angle, 90 degrees. If I go halfway, that's about 135. And we can see that she flexes beyond that. So almost to 145 or 150. So that's relatively straightforward how to measure flexion and extension. Next, which can be a little bit more difficult, pronation and supination. To do that, I measure both arms at the same time. So I stand in front of the patient. I'll have them tuck their elbows into their side. That prevents them using their shoulders to do any rotational motion of the forearm. So elbows are going to be locked in, and I demonstrate to them what I'm going to have them do. So first, do like this, perfect. And when I'm looking, so here she is in maximal supination, I'll take my hands and just give a little gentle pressure to see if there's any additional supination left. Also, it's very important to look at the distal radius and ulna rather than the hand, because you can have some rotation through the carpal bones of the wrist, which is obviously not coming from the elbow. So when I do this, I usually like to hold on to the distal radius and ulna to get a good feel for where that supination is. Pronation is the same thing. So we'll move in, again, filling the distal radius and ulna and taking it to the max or extreme. So that's how I measure elbow range of motion. Next, we'll move on to the medial elbow exam. So on the medial side of the elbow, the exam is really organized based on the anatomic structures on the medial side and the most common pathologies that we see. So if we think about what is on the medial elbow and what tends to go wrong, the most common things are the ulnar nerve, medial ulnar collateral ligament, obviously very common injury in throwers, and then finally the flexor pronator or medial epicondylopathy, or also called golfer's elbow. Those are the big 3 things that we'll see on the medial side, so that's what we'll focus our attention on. So when we take a look at the medial elbow, we'll start with the ulnar nerve. The first thing I'm going to do is take a look at the arm through an arc of extension and flexion. And here I can see the medial epicondyle is very obvious. The ulnar nerve obviously resides just behind it here. Very common to see ulnar nerve subluxation. Her ulnar nerve does not subluxate, but I can trap it right here with my thumb. So here it is between medial epicondyle, ulnar nerve, and then my thumb. I can trap it right there. So now you can see the ulnar nerve bulging out. And oftentimes, and then it snaps over as she goes into extension. Oftentimes that may reproduce their symptoms if they do have an ulnar neuropathy. Other ways of doing that or bringing it out are just a tap over the ulnar nerve to see if there's any sort of Tinel sign, which causes that numbness and tingling radiating down the medial aspect of the forearm into the 4th and 5th digits. So for her, she clearly doesn't have any of that. One other bonus tip that I will mention, if you do see a snapping or subluxating ulnar nerve coming back and forth over the medial epicondyle as you go from flexion to extension, that's one snap. If you continue to go and you see a second structure snap, that's the medial border of the triceps. So a snapping medial triceps can commonly cause irritation and pain on the medial side of the elbow. So next, we'll move on to the medial ulnar collateral ligament. So important to note that it originates on the medial epicondyle right here, and then it inserts on the sublime tubercle just distal to that. In the vast majority of patients, if you try really hard, you can actually palpate the sublime tubercle through the flexor mass here. So here's our medial epicondyle. If I track along right there, I can feel that's our sublime tubercle just distally. Now, it's important to note that if I were to draw a line bisecting the forearm, the sublime tubercle is in the posterior half of that. So generally, if they have medial ulnar collateral ligament injury, it's going to be in the posterior aspect of the forearm, posterior and distal to where the medial epicondyle is. So for me, I'm going to start by palpating the origin of the MUCL, the mid-substance, and the insertion on the sublime tubercle. And I'm looking for any areas of tenderness there. My next test and go-to test, this was developed here at Mayo Clinic by Dr. Sean O'Driscoll, as were many of the tests that we'll talk about today, is the moving valgus stress test. So for that, we're going to put the elbow in flexion, apply a slight valgus torque. Now, if they have pain with this, stop, the test is over, it's positive. However, if they don't have pain with that, then we're going to take them through a very gentle range of motion here. So while I'm applying that valgus load, I'm stretching the ligament, and then as I move back and forth, I am now shearing that ligament back and forth. So a positive test is one that recreates their pain and symptoms that they have at baseline. So those are my two go-to tests for the medial ulnar collateral ligament, both the palpation and the moving valgus stress test. Now next would be flexor pronator tendinopathy or medial epicondylopathy. This is probably the most common thing that you'll see in your clinics for medial elbow pain. So obviously the flexor pronator mass is a large group of muscles that insert here around the medial epicondyle and just proximal to it. Generally speaking, that shows up as pain along the forearm muscles in this region. So you can see it's generally more anterior than the medial ulnar collateral ligament, which is posterior here. So the location of their pain is very important. So first I'll ask for any tenderness of palpation in this area. Next, the test for me would be to have them take their forearm and your wrist and flex it up, hold strong, and don't let me move. And initially I'll try just some resisted wrist flexion to see if that causes any pain. If not, then I may add in a supination component. So now she is attempting to flex and pronate against my extension and supination. So to see if that recreates any of the symptoms here in the medial forearm. Now, two additional tests for this that were described here at Mayo Clinic. One is the medial tennis elbow shear test, which is another way, it's a dynamic way of doing what I just did. So in that test, I have them flex the elbow, make a fist, bend it down. So right now, she's firing that flexor pronator group. So I'm going to apply a little bit of resistance here. So you resist me. So now she's firing it even harder. And then next, I'm going to have her push forward to shear that tendon on the medial side of the elbow. So punch towards my hand, good. And now a little faster, good. And a little faster, good. So if it doesn't hurt at a slower speed, then I'll try it at a faster speed to see if that causes any pain or discomfort. The last test that I like to do for the flexor pronator group is something called a serving tray test. So you can use your hand, a book, any other object, or you just push down. What I'll have her do, open your palm here, and I'm going to give some resistance to her finger. So again, she is now firing these flexor pronators, and I'm going to have you push forward and back. So now she is shearing that muscle as well. So if that recreates those symptoms, then that would be indicative of a flexor pronator tendonitis. So those are my go-to tests for the medial side of the elbow. Next, we'll move on to the anterior elbow. So sticking with our anatomic-based theme, we're going to move to the anterior aspect of the elbow. And if we think about the most common pathologies in the front of the elbow, that would be either anterior impingement or a contracture, or biceps-related pathology. Those would be the two things that we'll cover here. So for the impingement, first, obviously we want to check to see what the range of motion is, and we already discussed how to do that. Next, if there is a limitation to motion, we want to assess the quality of that end. Let's say she only comes to here and then the elbow stops. Is that a soft endpoint or is that a hard endpoint? If it's soft, that's most likely due to posterior capsular tightness that's limiting motion. If it's a very hard or bony stop, then that's obviously going to be due to anterior impingement. So we want to assess the quality of that endpoint and also the pain. So if I come up and there's a very firm and hard endpoint that's stopping range of motion and that reproduces her pain, that's almost certainly bony impingement in the front of the elbow. If it's a softer endpoint and she has pain in the posterior aspect of the elbow, then that's going to be posterior capsular tightness. So that's sort of how I sort out bony impingement in the front versus capsular tightness in the back of the elbow. Now next, and probably one of the most common pathologies that any of us see in the elbow would be distal biceps tendon problems. The easiest way to look at that is using the hook test, which again was developed here at Mayo Clinic by Dr. O'Driscoll. This is a relatively simple test with an extremely high sensitivity and specificity, 100% sensitivity and specificity. So it's very rare that we have that on a physical exam test. In order to do that, we have the patient lift their arm and say, look at your palm. And then I'm going to reach around right here and hook the biceps tendon. It's not at all subtle, so you should be able to see that how well I can hook that tendon. Now, if I can hook this tendon and it's robust and she doesn't have any pain, that is a normal test. If I hook the tendon and it's painful, then I would call that an abnormal test, meaning the tendon was palpable, but it was painful. If I'm unable to hook anything at all, that's abnormal, means the tendon is ruptured. So obviously, if you can't hook anything, that is usually indicative of a complete rupture. If you can hook something, but it's painful, that often indicates a partial rupture of the distal biceps tendon. So that covers it for the anterior elbow. So next we'll move to the posterior elbow. Very similar to the anterior, as all the structures are sort of analogous. We're really going to look for contracture or posterior impingement, and then we will also look for triceps tendinopathy. So just like we did in the front of the elbow, what we'll do in the back is we'll assess extension. If there is a block to extension, again, we ask, is that a firm block or is it a soft endpoint? If it's soft, that probably means it's an anterior capsular contracture. If it's a firm endpoint, that probably means bony impingement in the back or potentially loose bodies that are in the olecranon fossa that are blocking motion. And again, we want to ask not only what is the quality of that, but how does the patient feel? Is that painful? If so, is the pain in the back or in the front? That helps us know where that contracture is coming from. And then next, very similar to the front of the elbow, the other structure in the back would be the triceps tendon. So triceps tendinopathy can occur very commonly. So typically to do that, first we want to see if the patient can actively extend their own elbow. If they can't, then we would be concerned about a potential triceps rupture. Oftentimes though, with partial tears, they can extend it and have reasonable strength, but they'll have pain in the area. So in order to do that, I'll have them push against me here, resist. So I'm checking her triceps strength. And then if that's painful, or even if it's not, I'll reach back here and palpate the triceps just proximal to the olecranon. So I'll feel that. Any pain there at all? No. And then I'll try it with resistance, push against me here. Good to see if that brings out the pain. If it doesn't, I'll try it in a different position because occasionally it may hurt in deep flexion, mid flexion, or near full extension. So it's important to check that at multiple locations. So that's basically it for the posterior aspect of the elbow. So now we'll move on to the lateral side of the elbow. And thinking about the structures on the lateral side, the main things that you can have issues with, the radiocapitellar joint being the most common, lateral epicondylitis also extremely common. And then lastly, we'll get into posterolateral rotatory instability, which is difficult to assess and makes it one of my favorite things to look at. So let's start with the radiocapitellar joint. First thing to do is find it. So first, I'm going to find the lateral epicondyle, which should be pretty obvious and palpable on most patients. We're going to move just distal to that until I find sort of the divot here, and I can flex, extend, pronate, supinate, which really makes it pretty clear to me where that radiocapitellar joint is. Now, a few things to do here. One, you can assess for pain or tendinous palpation in this joint line. I also, if I'm concerned about the cartilage on either the radial head or the capitellum, such as in a capitellar OCD lesion, I want to feel for any crepitus when I pronate and supinate the forearm and flex and extend. Now, if I have somebody where that's what I'm concerned about, I'll first start by palpating. Second, I'll add the motion in, and then if needed, I'll apply an axial load. So now I'm pushing down and compressing the radiocapitellar joint while I'm feeling here, and then I will shear the cartilage by pronating, supinating, flexing, and extending to see if that recreates any of the symptoms at that radiocapitellar joint, which might be indicative of a cartilage problem on either the radial side or the capitellar side. So that's the majority of the exam for the radiocapitellar joint. Now let's move on to the lateral epicondylitis, or tennis elbow as it's often called. And again, most of these tests are very analogous to what we did on the medial side for medial epicondylopathy. Again, large group of muscles that inserts here at the lateral epicondyle and just proximal to it. So generally speaking, patients will have pain or tenderness of palpation along this. Most of them will come in having already looked up the diagnosis, and they'll tell you that this is what they have. So it's sort of the burden is on you to prove that that's true or not true, and convince them or unconvince them. So we start with palpation of this area to see if that reproduces any of the symptoms, and then we're going to start doing some provocative strength testing. So for that, one of the things I'll do, extend your wrist, hold strong. So I'll start with just some resisted wrist extension to see if that causes any discomfort or recreates the symptoms. Next level up from that is I will add, so right now I'm attempting to flex and pronate the wrist. So she's attempting to extend and supinate. So she's really firing these muscles. So now I'm pulling in two directions to see if that recreates her symptoms. Next would be some of the more dynamic tests. So just as we had the medial tennis elbow shear test, this is the lateral tennis elbow shear test. So she'll flex up, extend the wrist, and I'll provide some resistance. So now she's working pretty hard to extend that, and then push your wrist towards my hand. Initially go slow, and then a little bit faster. Perfect. So we're having her fire these muscles, and then with the motion, she's shearing them. So that test, be careful though, in somebody who has pretty severe lateral epicondylopathy, that can be extremely painful. So start slow with that, otherwise they'll be pretty unhappy with you. And then lastly, one of my favorite tests for the lateral side of the elbow is the laptop test. Again, it was described here at the Mayo Clinic. And this test I love because often as I start to do it, patients will tell me, no, I'm not doing that because I know it's going to hurt. It's so practical, and it reflects sort of everyday life. So for that, generally what we do is it's basically just mimicking taking a laptop or a book up out of a bag. So I'll have you reach, grab the top of this, and then pull it up, and I'll resist. So basically just pulling up to see if that recreates their symptoms. So those are all of the main exams for both the radiocapitellar joint and lateral epicondylitis. Next, I'll show you our go-to test for the posterolateral rotatory instability. The best test for that is the posterolateral rotatory drawer test. For that, we prefer to have the patients lying down. So now I'll describe my go-to examination maneuver for posterolateral rotatory instability of the elbow. A couple things that I think are important to remember. Now, there have been a lot of different techniques to assess PLRI that have been described in the literature, but my favorite and preferred, and I think the one that's been shown to be the most sensitive, is the posterolateral rotatory drawer test. So that's what we're going to show you here in just a second. Now, to understand how to do this test, I think you have to sort of be able to conceptualize the pathology that's actually happening. One of the things that's important to remember is that this is usually due to insufficiency of the lateral ulnar collateral ligament, or the LUCL. However, the annular ligament is usually still intact. So that means that the radius and the ulna are still attached to one another, but both bones rotate in a unit off the back of the humerus. So if you can keep that straight in your head, I think that really helps with the examination maneuver. So for this exam, we're going to have the patient lie down on their back, and I'm going to have you scoot all the way up to the end of the bed. So I'm going to start with the right arm and show you. Now, typically I would stand outside of the patient and do it this way, but so you can see, I'll step inside here. Now, the most important thing we have to do is be able to get a patient to relax for this. So to do that, we have to really demonstrate arm security. So I have her arm here. I'm holding it very secure. I'm not going to let her fall. So this way she'll trust me. So in order to help with that and to free my hands up, I put the arm between my side and my hand, and I'm holding it nice and secure here. And now I'm going to take my hands and I'm going to go underneath with two fingers, underneath the radius. I'm going to control the humerus with my other hand. And now this gives me the ability to do different degrees of flexion and extension. I can also apply varus and valgus. But more importantly, with this hand, I'm going to apply a posterolateral rotatory drawer to the radius. So with 2 fingers underneath the radius, I'll first try some gentle extension. I'm just going to lift and rotate off the back. And then as you can see, I'm moving it through a gentle arc of flexion and extension, because they may have instability in certain arcs of motion, but not in others. So I think it's very critical and important to assess in all degrees. And you can see she has a slight amount of rotation of the radial head off the back, but this is normal, certainly not pathologic. If it were pathologic, we would be looking for a prominence here of the radius or a larger indentation here where the capsule gets sucked into the anterior aspect of the joint. So clearly, this is a normal exam. Now, I would like to show this to you on a model, and that may make the pathology make a little bit more sense. So here we have the arm in the same position that we just had our patient. So we pulled the arm up overhead. So now you're looking at the lateral aspect of the arm here. Humerus is going down to here, shoulders there, and obviously the hand is here. So I'm going to use one hand to help stabilize the humerus. And then with this hand, my fingers are underneath the radius. And with that hand, I'm going to apply a posterolateral rotatory drawer. And if you pay close attention right here, what you can see is the radius and ulna rotating together as a unit off the back of the distal humerus. So that's what we're looking for. And when we see that, we're going to see some capsule that sort of gets sucked into that defect, and we're going to see the radial head being prominent. So hopefully that helps illustrate what's going on with posterolateral rotatory instability of the elbow. So I hope that's helpful for you. That's a relatively comprehensive examination of the elbow. Again, I think some of the key takeaways are to divide it into the 5 sections as we described. The order is not really that important, but range of motion, anterior elbow, medial elbow, lateral elbow, and posterior elbow, I think are the keys. Generally for me, I vary the order that I do these in, so I'll save the area that has the most pain for last. And so I think that's been helpful for me. I'd recommend giving that a try. Thank you again for your time and attention. Thank you for Sarah for helping us out. Most of the techniques that I described and demonstrated today are available for you for further review in the peer-reviewed literature if you're interested.